Hello, my name is Fasiha Kanwal, and on behalf of my co-authors, I'll be talking to you about our study that is published in the current issue of Gastroenterology, the quality of care provided to patients with cirrhosis and ascites. As we all know, cirrhosis is a common and a growing problem, and ascites is the most common complication in patients with cirrhosis. There are several evidence-based guidelines that define the criteria of care and standards of care in patients with ascites. However, the extent to which these standards are met in routine care is largely unknown. We conducted this study to evaluate the quality of care provided to patients with ascites in 3 different VA hospitals between 2000 and 2007. We used 8 explicit Delphi panel-derived quality indicators to measure ascites care for this study. These indicators they're derived from a larger set of indicators that look at different care processes in patients with cirrhosis. The measures that we included in this study range from paracentesis after ascites diagnosis, paracentesis in patients who are admitted to the hospital, testing for cell count and culture in the ascitic fluid, antibiotics in patients who have spontaneous bacterial peritonitis or SBP, and secondary prophylaxis as well as primary prophylaxis for SBP in patients who are eligible for these care processes, and last, use of diuretics in patients with ascites. We did the study in 3 steps, and let me just go over them one by one. First, we used automated pre-existing administrative and clinical database from the VA in our cohort of 774 patients with ascites, and looked for adherence to these indicators in this data set. Second, we evaluated the relationship between different patient and non-patient factors such as demographics, liver disease severity, comorbidity, and whether a patient was seen by a gastroenterologist or seen in an academic facility, and receipt of care as defined by these indicators. And last, we went back to the medical records and did an implicit review to look for different explanations as to why a person did not meet recommended care. And we particularly looked for reasons that could represent justifiable exceptions or exclusions from the indicated care. Let me give you an example. A person who is diagnosed with ascites is eligible for diuretics, except if the person has minimal ascites on clinical examination. This minimal ascites may or may not be captured by the database, and we might miss it if we're just relying on the database. What we found in the study was that the scores on these quality indicators, they varied from as low as 30% for secondary prophylaxis after a documented episode of SBP to as high as 90% for testing the ascitic fluid for cell counts, for example. The other scores, they fell between these 2 extremes. In general, the care targeting treatment was better than the care targeting preventive care. We also found that patients without any medical comorbidity, those who were seen by a gastroenterologist and those who were seen in an academic facility, received better care. As part of our implicit review, we actually found that most of the patients who did not meet the recommended care did not have any documented explanation of failing the indicators in their medical records. However, some patients did have reasons that were documented only in their medical records that can potentially represent justifiable exceptions or exclusions to the indicated care. These reasons, these justifiable exceptions, were more common for 3 of the 8 measures that we looked at. These included doing a paracentesis after ascites diagnosis, secondary prophylaxis, primary prophylaxis for spontaneous bacterial peritonitis in patients with GI bleeding, and use of diuretics in patients with ascites. We therefore recommend that that these particular measures, these 3 measures, should not be applied to automated data such as the ones that we used in our study, unless chart review is also used to improve accuracy. For the other measures, automated data should capture the care because exceptions or justifiable exclusions were rare for these indicators. So in conclusion, what we found that the quality of care provided to patients with ascites, defined as if they received recommended care, was suboptimal and left some room for improvement. Care that was associated with gastroenterologists was better than the care that was not associated with seeing a gastroenterologist. And for some indicators, there are several exceptions, denominator exceptions, that limit use of automated data for accurate measurement for those indicators. Thank you very much.